do it. Okay, so
Let's see. Testing, testing.
testing, testing, 1, 2, 3.
Go for it.
Can you hear me? Okay, I'm gonna do my hair.
Fix your hair.
Okay. All right. Well, thanks a lot for having me. Pretty glad that I got this opportunity to kind of show you guys what I do for work. This is actually my first in-service I've done on this around, so this is really perfect. This is exactly what I needed. Give me a deadline, and then I can go around. So I've just obviously met all you guys, but Jimmy, and I run a mobile therapy practice here in South Bay. I'm a neurological physical therapist, and my practice is mostly focused around concussions, headaches, and vestibular therapy. Okay, I've been operating for about 2 years, 1.5 to 2 years. Okay, so just kind of about me and my background. So where I'm from, it's super confusing. I was born American, but then when I was 3, my parents landed jobs in China. So then I moved back to China. So I was an American national, ethnically Chinese person living in China. And then I came back to the States. So it's super complicated. If my Uber driver asks me where I'm from or anything, I just say LA. So, yeah. So a little bit about how I became a PT. So people always ask me, like, what drove me to PT? How did I end up doing what I did? And the answer is, like, I kind of just did it. So I was in undergrad, I was undecided. And then sophomore year, my advisor comes in and she says, oh, you need to pick a major, like, right now. So I said, well, I heard PT is a good career. I didn't know anything about PT. I thought I'd just be having people, like, sit on the cross balls or whatever. And then, but then the rest was history. And then I think, like most people, when I went to PT school, I was thinking more about orthopedics, so thinking about athletes and working more in the orthopedic injury realm. But I think it didn't take long for me to discover that I was actually more interested in working with a more disabled population, which led me to neurology, and then ultimately led me to headaches and vestibular therapy. Outside of work, what I like to do is I'm a musician. So these photos are actually from about 2 months ago when I was in a music video in LA. This is my dog, Ace. She's the only crazier person I know than me. So yeah, she's nuts. She chases airplanes and stuff. She's pretty crazy. So hey, how's it going? Okay, so I think today's topic of discussion is concussions, but before I start talking about concussions, I kind of want to zoom out a little bit and talk about headaches in general. So there's a document out there, it's called the International Classification of Headache Disorders. And if you look in it, there's actually over 300 different kinds of headache disorders. So I think headaches are kind of underestimated and misrepresented. They don't have much representation in the healthcare field. So once you start kind of looking deeper into headaches, you actually find there is actually a lot of depth there. So here's a list of some common headaches and some less common headaches. Things that we treat as physical therapists, we do concussion and we do a lot of cervicogenic headaches. And we have a role to play in pretty much all these kind of headaches. I wanted to point out migraine. So we kind of all know about migraines, kind of sensitive to light, sensitive to sound. But if you kind of dig into it more, you're going to see there's actually all kinds of different kinds of migraines. So there's vestibular migraine, atypical migraine, trigeminal autonomic cephalalgia. That's also kind of a separate branch of migraine and has its further criteria. And migraine is actually the second leading cause of disability in the world. So just behind low back pain. And another thing I want to point out is kind of cluster headaches. So cluster headaches is actually also termed, they're coined as suicide headaches. And the reason they're coined as suicide headaches is because they're one of the conditions that have the highest association with suicide. So that's how painful they can get. So that's how bad headaches can get for some people. So I want to talk a little bit about my history with migraine. I should preface this I was a competitive Muay Thai fighter up until about 2017. So before I started getting migraines, I actually have a history with concussion as well. But for other health reasons, I stopped Muay Thai boxing in 2017, and then I had my first migraine in 2019. So a bit of a gap there. So not really clear why that happened. No one really knows, but. Basically what happened in 2019 is I woke up to go to the bathroom and I was dizzy and I had a headache. And I've had a headache ever since. So it's been 5 years, nonstop.
So you have a headache right now?
Yes, 24/7. with a lot of facial pain and things. So this is a picture of me in the ER after a particular, one of several trips to the ER after a pretty bad migraine attack. And let me show you guys what led me to the ER. So let's see here. And hopefully it loads. Yeah, I'm just doing it with my hotspot here. Oh, there we go. Okay. Let me just pause that for a second. Okay. Yeah, you guys see that? So let's do that again. So when you see something like that, what are you guys thinking? What do you think it could be?
Like vestibular area.
Yeah. Yeah, exactly. So when I see something like that, I'm thinking cerebellar ataxia. I'm thinking stroke. I'm thinking maybe even a brain tumor. But I've done all the tests. I've had like 10 MRIs or whatever. All those red flags have been ruled out. So this is actually migraine. Okay. So when someone tells you they have a migraine, it's a lot more complex than you might even realize. I mean, this is a bit of an extreme example. There's even something called a hemiplegic migraine, where they get weak on one half of the body. So it literally presents just like a stroke, but it's actually migraine. There are people who have vestibular symptoms. They don't have a headache, vestibular migraine without headache. That's also possible. And then there's even something called stomach migraine, where you get all these stomach symptoms, but it's actually just a neurological condition more related to the brain. So yeah, super interesting stuff. And then this is Botox injections for migraine. So that's 31 injections all across your head and your neck. This is just before my spinal tap. And then after the spinal tap, I had a post-op complication called cerebral spinal fluid leak headache. So I don't know if you guys are familiar with that. Where basically when they go into the spinal canal, the hole doesn't close up properly. So whenever you're upright, your cerebral spinal fluid leaks out, dehydrates your head, and then you get a headache. So, basically had to lay flat for 2 weeks. This is from 2 weeks ago. I just got out of the hospital. So this was, my headaches are pretty hard to treat, obviously. So I underwent a 5-day infusion at UCSF Medical Center. I was hooked up to this IV the whole time. I named her Kathy. And Kathy and I were together for 5 days. And then it was an infusion of the medication called dihydrogen ergotamine every 8 hours for 5 days. So yeah, and then it's crazy. This thing, even though I'm out now, it takes 4 to 6 weeks for it to work. So I'm still waiting. So fingers crossed.
What is the goal of that medication? Is it anti-inflammatory?
So it works on basically the brain, and it's kind of like a system reset. Because migraine is basically an overactive brain. So something about the brain just gets really sensitive, and then some kind of trigger makes it kind of go haywire. So the idea is, I think it's supposed to kind of calm down the brain. Interesting fact: dihydrogen ergotamine chemically is very similar to LSD. So that's something interesting. But they took all the fun parts out, so it was all right. Just left all the side effects, But anyway, so back to concussions. So what is a concussion? And then the answer is, well, it depends who you ask. So there is no universal definition for concussion. So you ask the American Academy of Neurological Surgeons, you ask the CDC, World Health Organization, International Consensus on Concussion, they all have different definitions. And it's really hard to define because there's no test for concussion. You can't see it on imaging. There's no blood test that can diagnose a concussion. It really is just based off history and examination. And the severity of symptoms doesn't always correlate to the severity of damage. But I think for all intensive purposes, we can just think of concussion as a mild traumatic brain injury. And concussions are totally in right now. So this is search volume on PubMed. So this is like the amount of times people type in concussion into the PubMed online library. So you can see, not much interest, and then all of a sudden it takes off. And so concussion really is a very exciting field because this here, that's about 2010, 2011. And it takes, with medical inertia, it takes 7 to 8 years for medical research to go into actual practice. So when they say concussion is new and developing, it really is true. Yeah, it's a really cool field to be in right now. So treatment, cocooning is out. So cocooning is like the standard practice of, you have a concussion and you just put yourself in a dark room and then wait for the symptoms to resolve. that's no longer considered best practice. So it's unfortunate because there's not much common knowledge about that, both among like lay people and healthcare professionals. So people are still recommending this, even though they're finding it to be detrimental and less effective than an active rehab kind of program. And so what we want to do now is called relative rest. So relative rest just means that you're doing activity, you're just doing less activity than what you were initially doing. So quick, easy example is football athlete gets concussion, gets tackled, gets a concussion, can't go to practice, can't jog, can't run, but you want to start them walking. And then after running, you move to light, like incline walking, then a light jog. Then after that, they go back to non-contact practice and then back to contact. So I hate to read to you guys, but I think I want to point out a few things. Strict rest is not beneficial. So this is from the International Concussion Consensus on Sports Concussion in Amsterdam, and they state point blank, strict rest is not beneficial. Relative rest is defined as activities of daily living and light symptom-limited physical exercise. So the way we grade exercise for them is we kind of grade it by symptoms. So we want to provocate them slightly with our interventions, but not too much to get pushed over the edge, so we can habituate them. And then the last part is during the first 24 to 48 hours after initial injury. So let's chew on that. 24 to 48 hours. That's fast. That's really fast. I've never seen a patient that quickly. It takes them at least a week or two. If we're lucky, probably takes them longer before they start to see us. I mean, honestly, if I had a concussion patient and I knew it was 24 hours ago, I would still be nervous, right? But this is kind of where we have to kind of tackle our assumptions because, the research is very clear. You want to start as soon as possible, as soon as 24 hours after initial injury. It's not loading.
So you want to get them moving right after the concussion?
Pretty much, yeah. So, sorry, this Wi-Fi is slow. Yeah, you want to get them moving pretty much right away. So, here we go. So what happens? What's the pathophys of a concussion? So this is what happens during a concussion. Let's play that again. And then what I want you to pay attention to is this wobble. You see how it kind of wobbles? Like that? So, okay. So what causes the injury? So here's a neuron, and then here's the axon, and here's the neuron head or whatever. So then when it wobbles like that, basically the top is moving this way, and then the bottom is moving this way. And then that causes a shearing force on the axon, and then the axon, in extreme examples, the axon will rupture. But really what happens most of the time is the axon, the myelin sheath around the axon gets damaged. Okay? And then so that kind of makes the brain go haywire. Things aren't working as well as they should. And then so all those injuries on the axon is called a diffuse axonal injury, but it doesn't show up on imaging. So it really is just based off kind of examination. And then what that does is when that kind of happens, it causes a metabolic cascade, which just means all these different neurochemicals in the brain start going crazy. So if we look at it, this is what happens right after concussion. So here are some neurometabolic factors, potassium, glutamate, glucose, and you can see they just all go away from homeostasis, and it takes us some time to come back. But I think what we really want to pay attention to is this dotted line right here. So this dotted line represents cerebral blood flow. So you can see right after the concussion, the blood flow starts to dip. The perfusion to your brain starts to dip. And what we need in order to heal a concussion is blood flow. So that's why you want to start as soon as possible. You want to get these concussion patients on a symptom-limited aerobic program as soon as possible so that we can get this up sooner rather than later. Okay. Yeah, and then the way we want to do that actually is, so the way you do that is there's something called a Buffalo concussion treadmill test. And then you use the Buffalo concussion treadmill test to find a heart rate where they get provoked too much. And then you take 80% of that, and then that's the heart rate they work at 5 days a week. And then technically you're supposed to do it every week, or if you're lazy like me, you just say go up 5 beats per minute a week. And then, yeah.
So go up 5 beats?
Yeah, go up five beats per minute a week. Yeah, so say, for example, you find their symptom provocation at 120 beats per minute, 80% of that's about 96, 95. And then you do that for a week, 5 days a week, 20 minutes at a time. And then the next week after that, you go up to 101, 105, stuff like that. Yeah. It's pretty tough to do, actually. I don't know if you guys ever worked out and try to keep your heart rate within 5, but generally speaking, that's what you want to do. So how do we classify concussions? So they used to classify them by grades of severity, but like I mentioned before, there's no test. There isn't really any definite definition. So they kind of ditched that, and now what we do is we classify them by clinical trajectories. So concussions are like snowflakes. No two are ever alike. When someone has a concussion, they kind of have a mixture of all these different classes, but generally one is going to be more dominant than the others. So as physical therapists, the ones that we're really focused on, that we have the most impact, is the cervical trajectory, vestibular trajectory, and the ocular trajectory. Some of these other ones, you're going to have to start pulling in other healthcare professionals, especially post-traumatic migraine. I mean, this is the most difficult one to treat. If they start having migrainous symptoms, that's when you really need to start getting, some pharmaceuticals on board, in my opinion, anyway. So let's kind of go on. So here's a list of the symptoms for someone who has post-concussion syndrome. Post-concussion syndrome is when someone has the concussive symptoms for weeks or months after the initial injury. Those are the people we see, really. And then here's a list of symptoms for someone who has whiplash. So consider for a second, it takes 19 Gs of force to cause a concussion, but it only takes 4 Gs of force to cause a neck injury. So pretty much every single concussion injury is going to be coming with some cervical kind of component. And if you look at the symptoms of post-concussion syndrome and whiplash, you'll find they're pretty much identical, right? They're pretty much exactly the same. So that's where you really have to tease out where their symptoms coming from. Is it coming from the neck, or is it actually coming from the concussion itself? And that's going to really direct your treatment and how you move forward with that. Okay, so I can't talk about concussions without talking about balance and vestibular therapy. So, in school we learned there are 3 sources, 3 inputs to go into your balance. There is your inner ear, so your vestibular system, your vision, your eyes, and then this chart says muscles, but when I talk to patients, I kind of describe it as your feet, your proprioception, your sense of space in your feet. But I think there's a fourth piece missing, and the fourth piece that's missing is actually cognition, not concussion. So to kind of give you guys an example of that, so I'm going to ask everyone to stand up. So I'll stand up, yep. Some activity. And then so start doing, kind of moving back and forth through your ankles. Okay, keep your feet planted, so kind of like Michael Jackson. You guys know what I'm talking about, like from Thriller. Keep your feet planted the whole time. Okay, good. Okay, then start counting back from 99 by 7. 97. So keep your feet planted. You're only moving at the ankles, pure ankle strategy. Yeah. Okay, I'll show you guys another example because you guys are all doing it wrong. But because you want to keep your feet, so don't let your feet pick up. Yeah, just purely ankle, like Michael Jackson from Thriller. And then start going back for 99 again. Yeah. Or you know what, try this. Just stand on one foot. Try to stand on one foot and start counting backwards. Count out loud. So some of you already, as soon as you start doing that, it starts impacting your balance, okay? So that's where vestibular therapy is going, dual cog tasks, right? Adding cognition onto vestibular tasks. That's the rehab direction that rehab is going. And I think if there's anything I want you guys to take away from all this is that I think the dual cog task is probably the most underutilized tool in rehab. So, yeah, so even in even with my ortho patients, I'm always trying to include some kind of dual cog task in the rehabilitation. So okay. And then so this is a vestibular ocular motor screen. It's called the VOMS. This is my bread and butter right here. So we kind of go through these tasks with each person, concussion patient, and then you can kind of grade how much it affects their symptoms. And then whichever one is most kind of provocative, that's where you want to direct your treatment. So quick review. So smooth pursuits is when you just kind of follow my finger with your eyes, that's smooth pursuits. Saccades is, you hold out 2 fingers, you don't move your head, you look at one finger, then you look at the other, you look at one. Saccades, and then you can do it vertically as well. Convergence is, if you stare at your finger and you start breathing closer and closer to your face, your eyes converge, so focusing. Going away, divergence. VOR, so vestibulo-ocular reflex, is when you have your thumb out here, start turning your head, and then keeping your thumb in focus. Okay, so that's coordinating your eyes with your head motion. Do it vertically. And then visual motion sensitivity test, or also known as VOR cancellation, is when you do things like this. So keeping your eye in focus, but the environment is kind of moving. Yeah, you're moving. So these are what we kind of run through, and then based off that, that's where we kind of go direct our treatment.
And you're looking, is there, each one of those tell you a story? Like, or is it more of like you see the impairments, oh, we got to work on?
Yeah, so I mean, the technical way you're supposed to do it, you're supposed to do smooth pursuits first, and then you ask, okay, give me a 0 to 10 from your headache. Okay, give me a 0 to 10 dizziness. Give me a 0 to 10 all these things.
What does fogginess feel like?
So brain fog, it's really hard to describe. It's just kind of like this foggy, like kind of like, you're leaving your keys in the fridge, like, stuff like that, like that. Yeah, I don't know why my keys end up in the fridge sometimes, but it happens. And then that's how you're supposed to do it. Personally, for me, if I'm taking their history and they're giving me some examples, like they're saying, I have a really hard time with, grocery shopping when I'm looking around, that's the CODS already. So I might just test the CODS. And I don't really go through all these. I'm just like, I just think it's so annoying when you're just kind of doing that all the time, yeah. So I just kind of ask which one makes you symptomatic, and then I start treating right away. And then, you can start squeezing the other ones in throughout the treatment plan. So that's how I do it. It's not by the book, but whatever, yeah.
Real world application.
Yeah. So I kind of want to show you guys some exercises that I do. So you guys are all pretty advanced, so I busted out the big guns for you guys.
I
So
have bad history of concussions, man.
do you?
Too, I'm probably jacked up.
Oh, okay. Well, so this is it. So this is an umbrella, and then so we can do smooth pursuits. Oh, I left this guy on. See? So what we can do for smooth pursuits is, can I have a volunteer? Anybody? Yeah, so let's do, why don't we do, let's do 2 colors. So we'll do blue, and you can ignore the letters for now, but we'll do blue and we'll do purple.
Oh, this is like a man-made bits.
Yeah, pretty much.
Bits?
Yeah, it's
Yeah.
a big ass screen.
Oh,
Yeah, so I work out of my car and I go to the home, so I just kind of have to make a lot of stuff up.
that's cool.
Yeah, I spend half my time at Michael's. Michael's and Home Depot, yeah. And then, I'm not very good at arts and crafts, so everything just comes out super janky, but whatever.
It works.
Yeah, so we got blue and purple, so why don't you keep your eyes on the purple. Okay, don't move your head, keep your eyes on the purple, and then why don't you switch to the blue. And then, adding some cognition to it, right? I don't have to just say blue and purple, I can say, can you look at the not blue? Can you look at the not purple? Right, different ways I can do it. And that's not too hard because you're just kind of bouncing between 2. But one that I like to do is, so we have some, you see the letters A, B, C, D?
Yeah.
Okay, so A is 1, B is 2, and C is 3, and 4 is D, okay? So can you keep your eyes? Okay, do 2. Do 3. Okay, now do 3 minus 2. Yeah, 2 times 2. Okay. Why don't you call out the letters for me while you're doing it? Yeah. So 2 minus 1.
3.
Yeah, 2 plus 3 minus 1. Tell me the letter. What letter?
Oh. You gotta do that.
Yeah.
Was it 2 plus 3 minus 1? 4?
Yeah, there you go. So you see how hard can it get?
D.
Yeah.
D.
D, okay. Right. So this is pretty good. So, but what I can also do is, why don't you start doing forward lunges? Okay.
Okay.
And then so now we're getting a convergence and divergence kind of pattern. And then I can go in and out. I can
Starts to, like, trip you out.
I can move around. I can do all kinds of stuff. I can have them hold kettlebells or something. You can make this very difficult
Add
very
more
quickly.
layers of complexity as
Right.
well.
So let's do 2 plus 1.
3.
Yeah, there you go. 3 minus 2.
1.
Yeah, there you go. So does anyone else want to
So
try?
he would be looking at A
Yeah.
Yeah,
the whole time?
yeah. So
Okay.
The layers of complexity is like,
I've done this on the bits.
Yeah.
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 Okay, so let's do.
oh, it's 1. Then you can say A.
Yeah, 2 plus 2.
Dive into
Oh,
it.
for D,
D, there you go. Okay. And then let's do 1 plus 2.
C,
3 minus 2.
A,
Yeah. Okay. 2 plus 2.
D.
Yeah. So we can do
Okay.
stand on one leg. Okay, good. 3 minus 2.
A,
Okay, 2 times 2 minus 2.
D, B.
Keep your eyes on the thing. Yeah. So you see, you can kind of, and we can walk with it. We can move. So this is probably one of my favorite tools. You guys are pretty advanced, so usually a lot of times it's just kind of just moving it kind of back and forth like this. But you know, for you guys, we can do a lot of that kind of stuff. But even so, like I try to lay in some cognition all the time. So even the one where it's just like hopping between 2 colors, I'm gonna say not blue, not purple. You know, you're still hopping between the 2. But for someone who has a concussion, it just adds that little extra layer, that little extra oomph to it.
Lighting up more parts of the brain.
Yeah,
all
so
at the same
really trying to load the brain there. Let's do saccade. So
brain's like
Would
I,
the disco ball for us?
oh, I'll show that to you later.
Okay.
I don't think it's gonna work here today. Actually, it's too bright. But let's go to the zip blocks. And why don't we do? Let's do.
They are. I got kid sizes.
So let's do the ones with the numbers. So get 2 cards out that have the numbers on them. Yeah. And again, I got these all photocopied at Staples and cut everything myself, and so it's all like super janky. Yeah,
Get the job done.
gets the job done.
Roll on the east side.
Yeah. Okay, so what we can do is, so you'll have them out like this, okay? And then so you don't move your head, just keep your eyes, just move your eyes. So you do 8, 8, so look from one to the other, okay? And call them out. Good. Okay, so now let's do it. Let's do it standing on one foot, and let's do it from the left one, you go this way, 8, 9, 4, and then for the right one, you go backwards from here, 4, 0, 7. Okay, got it?
Wait, can you say that again?
So on the left one, you go this way,
Left to left, right to
and then the other one, you go this way from the bottom. Okay.
8, 4, 9, 0, 4, 7, 8.
Yeah, there you go. So yeah, you see already some of y'all already doing toe taps, kind of moving around. You start impacting your balance right away. Okay, cool. Cool.
I need to do more of this shit, man.
Yeah.
Play
Yeah.
set. Do you have set?
What's set?
Oh, it's a card game.
I'm always
I'll
interested.
bring it.
I'm always
I'll bring
interested
it.
in cog things that I can
So
add on top.
It's
On
like
top.
these 3 different numbers, 3 different shapes, and 3 different patterns.
Okay.
And you have to make different matches. It can be like 1s, 2s, 3s, or it can be shapes or all solids.
What's it
and all
called?
Stripes. Set.
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 I don't know, I'm gonna write that down before I forget.
All the cognition games.
Okay. What
What would
else?
be a training dose, like for somebody, like
So,
what would you dose something like this?
Try to build up to 2 minutes. Yeah, 2 minutes of doing that. Yeah, try to build up to 2. I mean, for a lot of people, it's probably just sitting, right, and then going slow. Build up to 2 minutes, and then basically with all these, you want to provoke symptoms a little bit, but you don't go more than 2 points. So you got a baseline. Right now, my symptoms are 3 out of 10. Okay, you work up until you get to 5 out of 10, and then you stop, and then relax, and then you do it some more, and then you just kind of build up that way. But I always try to, with all these, I try to build up to 2 minutes. 2 minutes.
One time a day, kind of thing. You usually recommend.
Huh?
One time a day.
3 times a day if you can. Yeah, start with once a day. It's dependent on everyone. Some people are really overwhelmed. They don't want to do any more than that. So, let's see. What else do we have? So let me get another volunteer so we can do this one. So kind of convergence. So anyone wants to do convergence? Okay. So can you start doing lunges towards this? Start doing lunges. Okay, and just read the word for now.
Blue, yellow,
Good.
green,
Okay. Now read the color and not the word.
blue, green, yellow, red. Oh, I read the next line.
Yeah, that's fine. Keep going. Yeah, keep going.
Keep going?
Yeah.
So I'm going to go to the third row.
Sure.
Yellow. Why am I
Yeah,
talking
it's
with my lunch?
hard, right?
Green.
And I can
red,
move it closer, right?
Green. Blue. Yellow.
Yeah.
Blue.
And then I can move it this way, so we're getting some cervical movement, we're getting some VOR, all
My
kinds of
brain.
stuff. Yeah. VOR. You can also do the same thing with this. So instead of doing the thumb, I mean, everyone does the thumb. So you can do this, and you can do the same task. So I think all you guys have one.
So you read it?
Yeah. And then let's
While you move
do,
your eyes, head.
while you move your head, and let's do it. Let me get my metronome on. We'll probably do 120. Okay, so, okay, start going.
What's the beats on that?
120.
120?
Start reading out the color, not the word. And it's not this. It's okay, faster, a little faster. Yeah.
I was going to the beat.
Yeah.
Blue, green.
And then some of you when they start slowing down, that's when you come in with your therapeutic touch and you come on top and you go like this, and he's super tall, so it's really hard.
I get dizzy.
Cool. Yeah, there you go. Cool. So there's that one.
Yeah. You
Yeah.
have concussion history too, right?
Yeah, probably.
Yeah.
I
Okay.
don't know.
That's probably good for now. I have a lot more, but I think you guys get the point.
That's pretty cool. It exposes to these.
Some other toys. So this one. So start doing it with complicated backgrounds. So I have this, and I can have them do it against this. I can move this. I can have them walk, and I can.
Looking at the card or what?
I might do the thumb. I also use popsicle sticks. You can like stick pictures on there, like if they don't like spinach, you can say no to the spinach and all that stuff. Like picture of your ex-wife, whatever. Yeah. Or I can like have them walk, and I can walk next to them with this in the periphery. And then we always do end up doing a lot of cervical stuff too. So sometimes you end up doing your shoulder too. So I always like to show this to people. So this is a body blade I made. So, body blades are like, what, $200 or whatever? Yeah, this is a piece of vinyl trim from Home Depot. It costs about $20 for the 12-foot long, and then you just cut it in half. And then you can have a little body blade. Yeah, there you go. So if you guys want to try that, you guys want to play around with that.
And when you do all the
It
same
works,
things.
it works perfectly fine.
Yeah, it works great. Yeah, all the same thing.
I got a body blade.
You bought one? It was like the same.
Yeah,
Damn it.
Was it vinyl trim?
vinyl trim.
Yeah, jeez.
Yeah, that's strange.
All right, that's it. Any questions about anything?
Cool.
Shoot, what does timelines look like with this first time concussion person? Are they? It's like a 6-week kind of journey.
I think it's like the same as ortho, like 6 to 12 weeks. Really, it depends kind of. I mean, if it's post-concussive syndrome and they've been coming in, 3 months after and it's been lasting that long, then it's just you just kind of don't know. It just kind of
So this is
depends.
the training, and then you just reassess the whole VOR saccades and everything again until it starts to get better and better.
Yeah, pretty much. Or if you want to be like really good about the outcome measures, they have things like the post-concussion symptom severity scale, or
Oh, the outcome measure.
yeah, the outcome measures, stuff like that. I like the bombs personally. And the most important thing is whether they're returning to the activities they want, right? So you have to coordinate with them, and if they're a kid, you have to coordinate with the school, like kind of easing them back into learning. Yeah, so you want to do return to learn before you do return to play.
You ever do like non-dominant eye kind of stuff where they're
Non-dominant eye? No, I've never heard of that.
so if you put an object in your you make like a diamond, if you look at an object and you bring it close to your face, you'll figure out what your dominant eye is.
Oh,
And there's stuff where they make you close one eye and then you do like saccades and stuff. It's from IKN.
that's interesting.
Astigmatism.
I learned it from IKN where
What's IKN?
integrated kinetic neurology. So they talk about like how your non-dominant eye takes more cognitive energy to process information. So they're making you do things to habituate it, because like if you're looking information from your non-dominant eye, you'll lose processing power for like muscle strength. So they'll make you do stuff with your non-dominant eye, and then they'll retest like muscle strength, and things like drop off really quickly.
Oh, interesting.
It's interesting stuff.
I'll have to
It's
check
like
that
you layer
out.
it into like the stuff that you're doing now, which is kind of cool.
Yeah, I'll definitely check that out. Oh, the disco ball. So I don't. It's probably too bright here,
Or you like,
but I kind of, I can just
oh damn.
see, and then now we're in now we're in a busy environment.
So what am I doing with this one? You're just moving it.
So we're probably still. So sometimes you just have them look straight ahead, and then you just spin it, and that's all you have to do. Or you can have them do some of those VOR tasks and stuff, and you can still have this here, and you can spin it just to make the
You know
environment
what'd be
busy.
interesting? Going back to that VOR test really quick, and walking through like what dysfunctions are you looking for? Like, is there an eye, thing going on or lag?
So I think with concussion, it's more symptoms. It's not like a vestibular
where it's, like,
hypofunction,
nystagmus.
where you can see like nystagmus, or you'll see their eyes like, not move properly. With concussion, it's generally more symptom based, but sometimes you'll see it. So like with saccades, maybe they'll go too far and they have to recorrect. So they do more corrective saccades. VOR, you don't really see it. What happens is they just start really slowing down their head. And then with convergence, sometimes you'll see a slip. Sometimes you see a retinal slip as you're coming in. It kind of slips in and slips back in. So that's about it. Cool. All right, well, thank you guys so much for having me. Yeah, I'm really trying to see as many headache patients as I can. So if you guys know any headache person needs some home therapy, we'd really appreciate
And
it.
you're mainly only going to their home as an option?
Exclusively.
Just the South Bay, or where do you?
South Bay.
Just one
Yeah,
South Bay.
just South Bay.
What's your cutoff going up? Like Santa Clara?
I go up to Palo Alto.
Oh, okay.
Yeah, I go up to
Okay.
Palo. I live in Cupertino, so basically half-hour radius around Cupertino.
Okay.
Yeah, that's what I do.
Yeah, general ideas.
Yeah, yeah.
How would you like them connected with you if we did refer? Is it text thread or?
Yeah, they can just call me.
I usually do an introduction.
I think-
text thread.
Yeah, call me, or you can write an email intro or a text thread. Let me give you guys my card.
Cool presentation, man. You're gonna have to
Thanks.
go and do this.
Yeah, it's good,
different,
dude.
Yeah, no, first in-service I've done on it. Yeah.
It's like under service, right? Like like you gotta. It's like really cool that you're niching it a little bit.
We
Yeah.
dropped some knowledge too. I didn't know there's 300 different types of headaches.
Yeah, 300 headache disorders.
that.
Yeah. So,
What's the ITPT?
impact trained physical therapists for concussion. Yeah.
It's a lot of acronyms.
Yeah, I have a lot of letters. I went a little crazy.
But is it because it's driven by your personal journey too?
Yeah. Yeah, I just want to work mostly with headaches. Yeah.
Because Kim
Oh yeah.
was dealing with, she had the trigeminal pain pattern thing going for a while.
She's gotten a lot better with it.
Yeah.
Like trigeminal neuralgia or
Something, it was wild.
She had some crazy headache thing, but when we both saw her, but by the time when she saw her, she was having this crazy headache thing, and then by the time I saw her, she wasn't having as much. It was more
okay.
like back pain.
Got her with a really high level osteopath.
Oh,
Yeah.
okay.
Like,
Is it
the
tick
face.
Wolverine?
Huh?
Tick Wolverine?
I don't know.
It's a trigeminal neuralgia, but then it shoots into their mouth.
Yeah.
I didn't see her at the time when she had.
Could be one of those trigeminal autonomic cephalgias we
Yeah.
talked about. Yeah.
That's what I was thinking when I saw
Yeah.
the term. I was like, man, I wonder if that's her issue.
That's what I have. Trigeminal autonomic cephalgia
Yeah, she gets it
with
crazy.
episodic ataxia. So it's a mouthful.
Yeah.
It's a real mouthful.
And like, it happens out of nowhere. Like, you don't even know how.
No. My biggest trigger is screen time. So no Netflix for me. Yeah. So that's also why I'm not really on social media. It's just too much screen time. Can't
yeah.
handle
Oh,
it.
I get it.
Yeah.
Editing.
Editing and filming. So I don't really do that
Actually,
either.
good for you.
Yeah.
Pick me another one.
All right.
All right.
Cool.
Send
Thank
them
you
up.
guys. Yeah.